Hi, my name is Alexis Reyes, and I had the opportunity to interview Helen Wong, who is a nurse informatics specialist too at Queen of the Valley Covina in Covina. A little bit about her. So she was a new graduate at Queen of the Valley, specifically on the med-surg unit. She received her BSN at Cal State LA. She was a floor nurse for 10 years, in charge for 9 years, and has been working in informatics for 15 years. So there's a lot of, so I had to ask her how exactly she transformed or she assimilated into the informatics portion of her career. And so essentially what was happening at the time was Queen of the Valley was still doing paper charting, and they decided to go into computerized charting. And so they pulled nurses from the floor, which one of them was Helen Wong, and essentially just basically integrated her on how to teach like the computerized charting to the floor nurses. But then for some reason, she got so interested in the world of informatics that she just stayed in the field. She never really had any further education, such as receiving her master's in informatics or any kind of specialty. She essentially just had to, one way she had to learn was go to seminars and meetings where she was with mostly other informatics. And I remember she was telling me she really had no clue. She was like, electronically deficient. And so she really strove to try to understand how informatics can help the nursing and clinical aspect and how she can make it better for her field. Let's see here. So I asked her what the value of informatics is in nursing care. And so she really emphasized the importance of integration of standards of care for certain disease processes that basically auto-populates in the EHR. That's supposed to be say EHR, but autocorrect, sorry, for providers and healthcare workers to review. So essentially what this is, how this is used in our setting is we have something called meaningful use, or the P protocol, which basically if you click on it, it says all the policies of the hospitals and all the procedures under that intervention or medication. So let's say if you're curious about how high up you should be going on a levofed drip, or what's your max dose, or what's your starting dose, you can just click on the protocol and it'll tell you what the hospital protocol is. So it basically made it easier for hospital providers to look for policies and procedures without having to really hunt down for it. So that's something cool that she was able to let me know about. And some safeguards and decision-making support tools that she was able to let me know about with Meditech Expanse. In addition to the pre-protocol, there are things like the Columbia Suicide Screening Tool, which basically says that, hey, if you answered a yes to any one of these questions, the system is going to suggest ordering a social service consult. It is just a reflex order, a suggestion to basically make you think, hey, that would be a good idea, or maybe I can discuss it first with a doctor. But it is something that basically can help the patient and make it a safer care for you. And then there is also the wound care assessment tool, which I believe if you document a stage 2 and up, it will reflex the order for a wound consult and a dietitian consult. So basically, these tools help the providers think that, hey, maybe this might be a good idea to order. It wouldn't be bad if we order these things. It might be actually safer. It might help the patients heal better. So these are the safeguards and decision-making support tools that kind of are integrated in the Meditech Expanse. Patient care technologies, the newer ones that she was mentioning was the Abbott ID for COVID-19 detection. So this is like a handheld device that determines whether the patient is positive for COVID in 15 minutes, more or less, just with a nasal swab in the nose. And they are currently working on utilizing more of these handheld devices, specifically at Queen of the Valley. They're trying to create this handheld device for specifically treating stroke patients. So, and you know how stroke is very time equals brain. So what they do is with these handheld devices, let's say it's like a cell phone or something. They basically get, it's like like the glucometer where you put the blood into the strip. It'll tell you what the result is, but this is for stroke. It'll tell you the Chem8, the troponin, prothrombin time, all within seconds at bedside. So I think this is really interesting and fun to interesting, and I hope to one day work with something like this because it could save a lot of time and it could save the patient ultimately from further damage. Currently, she is working in the maternal child department. She's overseeing basically that department at Queen of the Valley regarding their breastfeeding data for perinatal core measures. So essentially, these are for she gathers all the data regarding the documentation that was done on breastfeeding, and so they make sure that you know the data that they receive is accurate enough for measurement, and whether there needs to be some revision with the questions, or whether they're meeting standards for what the government really requires from them. So that's what she's doing. As far as a magnet journey, she's really unsure of whether our hospital is going to decide to go through that route. We are a nonprofit hospital, so we lack a lot of resources, unlike Cedars, unlike UCLA, those big hospitals. So we lack a lot of resources to proceed further technologically. But hopefully one day we can proceed further. And she said that's usually like a leadership department's decision anyway. So, but as of right now, no. Her relationship with the IT department, it's really, I was really confused in the beginning because I wasn't sure exactly what was going on in the IT department and how she kind of played a role in there. So essentially, it's one whole department, two different worlds. There is the informatics side, which is your clinical side, your nursing side, and there is your IT department, which is your technical side. So what she does, what Helen does, is basically knows what queries to pull up if she needs data regarding her breastfeeding data. She basically knows what queries to pull up, and so she speaks with the IT department or basically the programmer, to attain the data she needs to gather, to basically present to her director. So usually they work just like that. One is clinical aspect and one is more of the technical side, where they can print out the data, the data sheet that she requires in order for them to see whether their interventions are working. So from one of the questions I asked her was what her role was from Meditech to Expanse. And so her role during the transition was to tailor the EHR to the nurses who will be the end users. So they basically, same thing that happened to Helen when they first went from paper to computerized, they took floor nurses out. And so Helen was able to work with those floor nurses to basically create a more customized electronic health record that basically tailors to different units like CCU, MedSurg, Tele, things that, and they basically worked on things that they could save time on, but also be appropriately documenting. And so once they built the system in a matter of months, I would say, they basically, once they went live, they had a go live party. And so Helen was one of the teachers, but it was also the staff nurses who helped create the system basically taught it to us, and I think also in a month's time as well. And I just remember it was just way better from black and white to something with a little bit more color and a little bit more easier way to navigate through. So I asked her about garbage in, garbage out, because I wasn't sure what that exactly meant. I had an idea of it, but I really wanted to confirm with how she was able to, how this concept applies to her. And so basically, if there are questions on the assessments that needs to be taken off because it's throwing off accurate data, they're going to just take that question out, or they'll revise it. So in order for Helen really emphasized the fact that if they want the right information, they have to have the right assessments, the right responses to generate the right information so that you do not get garbage. So this is basically just getting rid of like garbage data. So that way it doesn't waver them off. Reflection after interview, honestly, I have major respect now for the field of informatics. Before, I wasn't really sure, or I wasn't really paying attention much to how it affected me or how it influenced me. But when our system got hacked and we went from computerized to paper to learning a whole entire new system, I could see why the world of informatics and the IT department are very important and integral to that. Because if not, I mean, some hospitals, some management would have just gotten a whole new entire system, dumped it onto us without having it, just plain general open, like out of the box type of program, without having customizations that help the end users save some time, be more efficient, be more with the patient, and make less mistakes. So after the interview, it was just nice to really get a whole understanding of what how her role and how the IT department really played a role in during our transition from Meditech to Expand. So a couple things that I loved with this new system is basically the shortcuts that make it easier to find protocols and policies, because I still don't know where to find them on the computer, but once I press the P, it just shows up something specific for that assessment. So for instance, the Braden scale. If I forget what criteria is the Braden scale, I just press that P protocol and it'll show up right there, and it's just easier for me to, it's just more accurate for me to make an assessment on my patient. It's just a faster time. And so also there are also reflex orders to double check myself, which are really nice. So some of these reflex orders you'll see on the providers is once they put like community acquired pneumonia, they will suggest these antibiotics that will help against the pneumonia. And so the providers can think, oh, that is a good idea, let's do that one. And so these are just like these little things I never really thought about until I started talking with Helen about how this really ultimately helped us. And as future providers, I feel like this is really important because we are the providers now. We're the prescribers of care essentially. So we have to really be double checking ourselves and making sure we're not making little mistakes that could harm the patient. So yeah, thank you very much. And yeah, thanks for listening.